Our next section involves two diseases, and we're going to talk about disease of the testes and hypogonadism. And we're going to keep this simple because we're only going to talk about primary hypogonadism, and secondary, it only involves one disease of each group of diseases. So the first one I'm going to talk about is the most important one. This is the most important one that you have to know about hypogonadism, and this is primary hypogonadism, Klinefelter syndrome. And this is the most common cause. Klinefelter syndrome is the most common cause of primary hypogonadism and hypogonadism altogether, because it occurs 1 in about 400 births. So Klinefelter syndrome is not uncommon. The problem with Klinefelter syndrome is that you have extra X chromosomes. So the most common pattern that we see is the 47XXY. This occurs in about 75–80% of the cases. And then the rest 20% of the cases usually have more X chromosomes or mosaic. And the more X chromosomes that these patients have, the more the abnormalities that they have. Patients with Klinefelter syndrome have the typical hypogonadism, right? That's typical. It's not only in Klinefelter syndrome, it occurs in other hypogonadic states and secondary hypogonadism, where you get gynecomastia, the small testes, sometimes the female distribution of fat, and so forth. Because Klinefelter syndrome is primary gonadism, so basically you have an end organ problem, end organ damage from the extra X chromosome. The initial problem with Klinefelter syndrome is a decreased testosterone level, because the cells producing testosterone have a problem. They malfunction. What that does is it causes a positive feedback back to the pituitary and increases LH, luteinizing hormone. And this also causes a positive feedback all the way back to the hypothalamus, and it causes increase of GnRH, or this thing called gonadotropin releasing hormone. So testosterone is low in Klinefelter syndrome because end organ damage occurs, the extra X chromosome. The LH is elevated, and the GnRH is also elevated from the hypothalamus. These patients are at increased risk of breast cancer. They may have some risk about testicular cancer, but please remember this last thing. This is very, very important here, that they have increased risk of breast cancer. They're 20 times more than any male. Now male breast cancer is rare, but in these patients, they're 20 times the risk of any patient, any male patient, to get breast cancer. So these patients have to be looked at every year. Make sure they don't develop breast cancer. The treatment is testosterone. What are they missing? They're missing testosterone, so we give them testosterone, and that alleviates most of the gynecomastia and the hypogonadism. The second syndrome that we have to know a little bit about is a form of secondary hypogonadism. This is called Kallmann syndrome, and these patients have a very interesting disease because they have an isolated decrease in gonadotropin releasing hormone. Remember, I just said to you, that's the one from the hypothalamus. So the hypothalamic hormone is decreased, and what this causes now is further decrease in FSH and especially LH, and now this is what decreases the testosterone. So it's important, the end result of secondary hypogonadism, Kallmann syndrome, is the same thing as Klinefelter syndrome, but the hormonal process is different. For example, in Klinefelter syndrome, testosterone was low, but all the other ones were elevated because of the positive feedback. Here, it's GnRH that you have an isolated deficiency in Kallmann syndrome that decreases GnRH from the hypothalamus, then you get a decrease in the pituitary, then testosterone is decreased. Now this is X-linked. It's a single gene defect, and these patients also at the same time, along with the secondary hypogonadism, they have anosmia. They have gynecomastia, the small testes, just like Klinefelter syndrome has, and I told you now they have low FSH, LH, and low testosterone, and the treatment of this disease is you either give them testosterone, what they're missing in the end, or some people will give them synthetic GnRH. Now there's forms of synthetic GnRH, so they're missing this as a single hormone, and you give it to them and everything is pretty much normalized after that in terms of their hypogonadism. If you treat the hypogonadism correctly, if you treat the low testosterone correctly, the hypogonadism goes away, but the anosmia basically is permanent, doesn't go away. And I just want you to remember that. So basically, secondary and primary hypogonadism look exactly the same. Sometimes they're treated differently depending on which hormones are missing. And we have to remember the Kallmann syndrome, which is associated with secondary hypogonadism, a single gene defect, decreased GnRH, and anosmia, and Klinefelter syndrome, which is primary hypogonadism and an extra X chromosome. And this is the end of our hypogonadism and endocrine session.